I am Sergeant James Sandberg of the Delta Police Department, and I am here to speak to you today about the strategies and approach the Delta Police Department is taking when dealing with mental health-related calls for service. Thank you to the organizers for inviting me to present today. I'm passionate about what we, the police, do, and these opportunities to share with our partners will make all our services deliveries better. The Delta Police Department is a municipal police agency in the suburbs of Vancouver. We have 200 sworn officers, a population base of approximately 130,000 people, 40,000 calls for service annually, and approximately 10% of those calls have a mental health component involved. When you do the math, that is approximately 4,000 calls per year or 11 calls per day. We have a mental health unit that is staffed by 2 full-time police officers and an NCO overseeing the unit. These officers deal with mental health clients in the community, conduct follow-up visits and outreach as required with people in the community who are adversely affected by mental health, and work in partnership with our regional healthcare providers. Our public health care partner, Delta Mental Health, is a division of the Fraser Health Authority. Check well-being calls, mental health calls, suicidal person calls, person down calls, a variety of other types of files that all contain a mental health challenge. All these calls can be problematic for attending officers. They can be complex. Officers sometimes have the luxury of time to be able to assess the situation, but often these scenarios are assessed in mere seconds. And this is for a variety of reasons. However, the one constant in the officers' minds when attending these calls is about public safety. That includes the safety of the public, the safety of the affected person, and the safety of the officers involved. These calls can pose risk, and the level of risk is often the variable that removes the luxury of time in dealing with the calls. Use of force is occasionally used, but if you look at use of force statistics, any force used is less than 0.1% of the time. And when I say use of force, I'm including open hand control, taking physical control of a person and restraining them at a level that's higher than compliant handcuffing. Remember those 11 calls per day that I had mentioned at the start. That means statistically, use of force is used once for every approximately 1,100 calls for service, or once every 100 days. The BC Mental Health Act grants police the authority to apprehend a person involuntarily under certain criteria. First, it must be apparent to the police officer that the person is suffering from a mental disorder. And second, the person must be in imminent danger to themselves or another person. There are other apprehension provisions in the Act, but those other provisions are related to different mental health warrants that can be issued by doctors and courts, etc. For the purposes today, I'll be focusing on the involuntary apprehension. Our officers also recognize that often people may benefit from mental health intervention, but do not meet the criteria for apprehension. And in these situations, the officer can suggest voluntary attendance to a hospital or doctor for follow-up. The officer may contact the Delta Police Department mental health liaisons who conduct outreach and follow-up in the community with Delta mental health staff, and that unit may assist the person. DPD is not an agency that employs a CAR 67 approach. CAR 67 is an approach that employs a police car containing a police officer and a psychiatric nurse team that's ready to respond to calls for crisis. We do have full-time mental health liaisons. These liaisons do work in the community and they do work in partnership with Delta Mental Health. But we do not have a dedicated mental health car on the road with a police officer and a psychiatric nurse paired together. We may get there one day, but for now, the calls for service have not justified or supported the need. Instead, our patrol officers respond in the first instance for check well-being calls or persons in crisis calls, and the patrol officers do so utilizing 3 distinct components of training and experience. Those 3 components are crisis intervention and de-escalation, I'll refer to as CID, integrated communications and tactics, you may hear me refer to that as ICAT, and the third is Health IM. CID is a mandatory course developed by the BC Ministry of Public Safety and Solicitor General, Police Services Division. This course was developed in consultation with the Braidwood Recommendation Implementation Committee and a working group of police and non-police subject matter experts. CID is trained in-house by certified trainers that employs face-to-face training in a lecture setting, small group discussions, role player exercises, and a written test. This in-house training occurs only after the officers complete an online segment of the course through the Canadian Police Knowledge Network. On the slide, you'll see two of our officers engaged in a training scenario on our simulator. ICAT is also an in-house taught program taught by our own training section. In May 2017, a group of negotiators, trainers, and managers attended a seminar in Los Angeles that was sponsored by the Police Executive Research Forum. The seminar focused on strategies that police can employ to de-escalate people in crisis without jeopardizing officer safety. The concept focuses on utilizing communication and a variety of layered force options while engaging with an emotionally disturbed person. This approach is similar to the CID training. However, we're building on CID practices and formalize a standard approach that will assist our frontline members who have had the difficult and challenging task of intervening in these types of incidents. And we love our acronyms. This is here where I'll introduce ILEAPS. ILEAPS is a roadmap for the communication portion of ICAT, and it stands for Introduction. Hi, my name is James. I'm a police officer, and I'm here to help. Listen. Give the affected person an opportunity to discuss their problem. Encourage it. Empathy. Paraphrase back. I see that you're upset. Tell me about that. Ask. Use open-ended questions. Can you tell me more about that? Can I ask you, please, to put the knife down? Paraphrase. So what I hear you saying is, and then finally summarize. How about we, and then spell out your plan. I will help you. Explain why, provide options, identify solutions, and work together with the affected person. On your screen, you'll see Chris. He's one of our officers, and right now he's engaged in a scenario, again, on our simulator with a person in crisis. You can see Chris is at a distance. ICAT would generally dictate that he put a layer or a barrier between himself and the subject, some level of cover, and he'd communicate from a distance. The third component of our strategy is Health IM. We began using Health IM in October 2019. It's a third-party application that assists Canadian police services in improving their mental health crisis response. The system provides a clinical screening tool and secure connection to local hospitals and community health partners. Since implementation, using Health IM, we've reduced our apprehension rates, decreased hospital wait times, and enhanced the care provided to citizens in distress. And we use it on our officers' mobile devices. So what it is, it's a tool our officers use to assist them in articulating their decision to apprehend or not apprehend a person. The officer inputs their observations into the app through a series of drop-down questions. These questions originate from the Inter-Eye Brief Mental Health Screener, or BMHS, and are designed to be indicators of risk of harm and the presence of a mental health disorder. If the officer apprehends a person, the report is sent directly from the officer's smartphone to the designated facility where the person will be transported. The report is presented in clinical language based on the input observations. If no apprehension is made, but the officer subjectively believes the person would benefit from mental health resources in the community, the officer will still complete the assessment tool, complete the application, and then the report will be forwarded directly to Delta Mental Health. Previously, This type of referral was already being done, but we were doing it manually after the fact using our mental health liaisons. Now, the officer making the observations can make that referral in the first instance, basically from the scene using the app on their smartphone. In terms of training, we're very clear with our officers. In order to comply with the legislation of the Mental Health Act, they have to have a subjective belief based on objective criteria that the person is suffering from a mental disorder and that they are an imminent threat to themselves or another person. Because of this, the officers are trained not to use the Health IM app to make the decision to apprehend or not. Their decision needs to be made independently of the app. The Health IM training occurs in-house. Initially, we hosted train the trainer sessions with trainers being embedded on each patrol shift. Those trainers were then responsible for ensuring their shift was trained on the use of the app and the process. The training comprised of a platform overview, an introduction to the BMHS process and workflow. What we have found over time since beginning the use of the Health IM app is that our officers' decision-making, their subjective belief, is slowly changing. Embracing the follow-up of the community by mental health outreach workers and liaisons, experience using the app and seeing empirical data from the BMHS has allowed our officers a better understanding of the situations they are seeing, considering new observations that previously had not been considered, for example, the presence of illicit drug use or medication compliance. These are now factored into the decision-making. Essentially, what I am trying to say is our officers' decisions to apprehend or not apprehend are less subjective and more consistent across the agency due to the implementation of Health IM. And that has translated to lower involuntary apprehension rates, less wait times at the hospital, less cumulative time at the hospital, a return of patrol resources to the road, and availability for other calls for service, and improved outreach availability for mental health resources in the community. So for me, this is really important because of where we anticipate seeing things going. With improved mental health outreach and resources in the community, the expected return on that investment is a higher level of community-wide mental wellness. And that means less calls for service to the police agency, the community mental health partners, and the health authority in general. So I want to take us back for a minute and look at what happens when an officer does attend a call to check the well-being of a person that results in an involuntary apprehension and delivery to the hospital. I want to break it down so the non-policing partners watching today can gain some insight into this entire process. So first we see the call for service, usually a third-party call to request the check welfare of a person or a call advising of another person in mental health crisis. The call taker will gather as much information as possible regarding identity of the person if known, the actions of the person, whether there's violence or non-violence. The call center will dispatch officers to the call. For calls like this, a minimum of 2 officers would be sent. This multiple officer dispatch occurs because of officer safety concerns. Research en route or prior to attendance. The attending officers will query the person for background information and knowledge. Reducing the unknown increases the safety of all involved, including the person who is the subject to the call. So with Health IM, we actually have the luxury of querying the person in the Health IM database as well. And if the person has been entered before, what we'll see is some entity details at the onset of the query, but more importantly, we will see some de-escalation advice and some triggers that are identified for the officer to avoid. So for example, and I'll be a little cheeky here, if the person responds really well to soft kitty, the officer might develop the approach to sing soft kitty at attendance. Likewise, if employment or lack of employment is a trigger for the person and the data has been entered into the database, the officer will see that and will know to avoid talking about employment or lack of employment. Attendance. This is where the officers will employ CID and ICAT. Attending officers establish contact and cover roles, meaning one officer will be designated to communicate with the subject person, while the other officer's primary concern and focus is the safety of all parties. The contact officer employs eye leaps and engages the subject verbally. In most scenarios, the subject will respond to some degree. Decision making. The officer makes the decision to apprehend or not apprehend in compliance with the Mental Health Act. For the cases of our scenario here, the officer has made a decision to apprehend. In this situation, the officer will advise the subject that they are being apprehended under the Mental Health Act and will be taken to the hospital. The subject is physically taken into custody. Once control is established, one of the attending officers will complete the Health IM screening data entry and send the report to the hospital. The report will arrive within seconds at the hospital, alerting staff of the pending arrival of the patient, the officer's observations, the degree of risk listed in a numerical scale on the report and determined by the BMHS, and any other flags that should be considered by the nursing staff that are designed for nursing safety. Flags that might be included are related to weapon possession, drug use, medication compliance. And also, just a note here, we have made the decision to share these apprehension reports in addition directly with our Delta Mental Health partners so that they can provide community follow-up as they see fit after the fact. This here is a sample report. I know it might be a little bit hard to see on the screen, but just really quickly, I'd like to go through the report with you so that you know what is included. So those flags for the nurse, designed for nursing safety, are just on the left side of the front or the first page there. You see the red triangle and the orange circles next to that. Those icons are designed to catch your eye and are designed for nursing safety. Above that is just the entity detail of the person, so name, date of birth, address, so forth. Next to those flags, you see three numerical scales, 9 out of 10, 8 out of 10, and 9 out of 10. Those are measuring risk of harm to self, risk of harm to others, and risk of self-care. So for our test subject here for this report that you're seeing, the graph on the first page shows a couple of really interesting things here. So the current assessment is the assessment that's on the far right of that graph. You can see the numbers are quite high on the graph. And what's interesting to me is the 4 previous times that this person has been assessed, there's been low scores. So something has happened. There's been a change in behavior or a change in mental wellness that has caused this person to spike. And that history is all displayed in the report and really valuable information. On page 2, what you see are the officer's observations that have been entered by drop-down menu. So the box on the left of the page, those questions are concerned mostly about mental health, whether the person is hallucinating or having command hallucinations, has any insight into their mental well-being. The column on the right are behavioral indicators, and those are what's used to determine level of risk. So it's laid out quite nicely. The officer has 3 options for each drop-down menu. It could be present within the last 30 days, but not present now, or present within the last 24 hours, or not present, sorry. So the circles can either be completely filled, half filled, or not filled. And the app or the BMHS algorithmically then produces those numbers for the risk of harm. And then the other thing that it provides us is some statistical information down at the bottom whether once a decision has been made at the hospital, whether the person will be held for assessment or released. The officer will go back into the app and complete a little bit more data, and that gives us some data that we can track and share for statistical purposes. Things like whether they are held, released. That's how we calculate our wait times at the hospital, is by the officer entering in the arrival and departure times from the hospital into the app and so forth. So following completion of the assessment, the officer hits sends and the report gets transferred to the hospital electronically, and then the officer transports the patient directly to the hospital themselves. Upon arrival to the hospital, the patient must go through a triage process and be cleared medically prior to be transferred to the mental health substance use zone, which is a secure zone inside Surrey Memorial Hospital. After arriving at the MHSU, the patient is assessed by a psychiatric doctor, and a decision will be made to hold the patient for psychiatric evaluation or release a patient now. Once the officer has a decision from the doctor, we consider the care of the patient being transferred into the care of the doctor from the officer, and the officer is clear to leave the hospital. So the officer at this point will then return to their police car, do their report writing, and return to service.